I started with the nursing assistant course.
Yes.
Then in the middle of in fact, after 6 months, they changed me to the general nursing course.
I see.
Yes. And then from there, midwifery.
Right.
And then I worked here.
Right.
I was employed here.
And how they trained you, especially in general nursing?
In general nursing,
right.
yes, and midwifery.
Right. And then you came you worked mainly in this clinic? Or?
Not really. I started working when I was employed. The first year I was working in the male ward, and then the following 2 years I worked in female ward and pediatric ward, and then I went down to maternity ward, and then after in 2000 I came up here.
Yeah.
But then 2005 I was away in Natal. The plan was to further my studies and work there to get acquainted with some other activities in the health sector in South Africa. But then, just to some problems, I happened to come back to Maluti now.
Right.
Here, I was stationed in female male ward in theatre, and then came back to wellness center. So
you've had
I've
really
been
wide
rotating.
training. Yeah, right.
I've been rotating.
If you don't mind, we'd like to understand the service at a community basis for the HIV positive people, how the epidemic, we like to see it as starting from the community. So you tell us how you see it, how patients come here.
Okay. In the past years, what we used to do, we were going to the community and giving them some health education on HIV, AIDS, and pulmonary tuberculosis or TB at large, and then we were giving them education with the hope that they would understand how important it is to know their status and everything else, and to test for TB if they have TB contacts in their villages. So that's how we were doing it, and then we're encouraging them, as we give the talk in the villages, we're encouraging them to come and do some testing in the wellness center, because the wellness center was already there since 1992, I think. It was already open, this department, and they were already doing some HIV tests, but it was difficult for people to come in here because they were labeled as they were already having it, even if they were not positive.
Yeah.
So people do come from those villages where education has been given continuously. They come and test, and they go out and encourage others to do the same. So they come from different villages. Some do come from, when they come to see the doctor for consultation down in the outpatient department, so the doctor refer them to the wellness center to come and do the test.
Right.
And that's how we identify them.
Right.
After doing the test and the test is positive, so they start the chronic care in the wellness center.
Yeah.
If they do agree, we don't force them to do so.
Yeah.
Because some they prefer to go to TY, some they are from Maseru, so they go to the nearest clinics as long as they're going to be given the care they need.
Right, right. Well, are there many places around where you could get the testing, or must they come here for the testing?
Yes, we have the clinics. We have the clinics in the remote areas. We have about 4 health centers in this area.
Yeah.
So even the health service and health centers, they do the test.
Right.
Others do come to.
Right. You do the rapid test?
Yes, it's a rapid test.
And you tell them right away the result?
Yes, yes.
Oh, yeah.
Yes, right.
Now, part of your group will come from the pregnant group. During pregnancy,
Yes.
you test everybody.
Yes, we test everybody, but we test those that come in the wellness center. Those who come for their antenatal clinic, they are tested down at the antenatal clinic.
I see.
So they do testing down there, and then they are referred up here if there is a need.
Right.
But
And they will agree in the antenatal clinic, they will agree for the testing. You have to explain there.
yes,
You give them counselling there.
yes, they give them counseling.
Not,
They are given the health education as general.
yeah.
And then they go individually for for counseling.
I see.
But the way they are doing it now of late, it's like blood is drawn, test is done, and then when the results are out, that's then they do the counseling and then disclosing the results.
I see. They don't count for before because the blood is the same blood.
Yes.
Everything.
Yes.
No. How long must they wait from the blood drawn to the?
Due to financial restraints, so they wait until the next visit.
I
But
see.
otherwise, the blood is done in 2 to 3 days.
Right, right. And they always come. They know they would at that stage. They don't know that they would come back for HIV result when they first come in.
Yeah, when they first come in, blood is drawn, and then when they come for the next visit, then the results are there, then they're disclosed.
Yeah.
Counseling is
So
disclosed.
do they know at the first visit that
The blood was drawn.
Yes, for HIV.
Yes.
Yes, and they agree.
Yes,
Yes,
they do.
they agree.
Most they do. There are few individuals, it's an exceptional people that refuse still,
Right.
but most of them now do
They
agree.
do agree.
Mhm.
It's changing.
Yes, it's changing.
Right.
It
And
is.
they all agree to hear the result. They come back for the result.
Yes,
of
they
the
do.
testing.
They
Oh,
do.
right. Let's take them from there.
Mhm.
Then what happens to them at that point? They come back if they're positive.
Yes.
Then they come up here.
No. At the antenatal clinic, since we have this new regime of
ALV.
PMTCT,
Yes.
they start PMTCT. It depends with when the lady was discovered to have the HIV. So when it's before 28 weeks, at 28 weeks they start the AZT nevirapine regime for prevention of mother-to-child transmission at 28 weeks. But if it is after the 28th week, then the nurses refer them to wellness center, and then they go for pre-heart counseling and they start the ARVs. Before delivery, they are already in the
I see.
antiretroviral.
Do they give them Nevirapine? Or they don't?
Yes, nevirapine. The regime says if the CD4 is above 200, it's nevirapine, but if it's less and something, it's efavirenz
Okay.
and AZT
Right.
and lamivudine. So it differs.
Right.
It depends with the CD4 count.
Right. And at the time the test is done, the CD4 count's done.
Yes.
Yes.
Before they get
Right.
the airways.
And so are they supervised in that at the antenatal clinic or here?
At the antenatal clinic,
They
those that come
supervise
from the
that.
yes, yes.
Right. Okay, and then the baby is born.
The baby is born. When the mother was already on the ARVs, the normal ARV
Yes.
routine, the baby is given the zidovudine syrup for only a week.
Okay.
And then if the mother was, that is when the mother was already on ARVs, and when the mother was already been given the prophylaxis
Yes.
of ARVs, then it's only 1 week. But if the mother only got the state doses of ARV
Yes.
because they didn't manage to give the prophylaxis, then the baby has to take the ARV prophylaxis for a month.
Okay.
That is 4 weeks.
Right. And then how does the relationship with the mother go on? Does she then come here when she's delivered and she's positive?
Yes.
Then she comes here to be further monitored with the baby, or does she go? Is she still with? The,
No, she comes up here
So you
with the baby. So
mother comes with the baby.
Yes.
Right.
So
and then you continue.
continue with the
Yes.
care.
And then I saw a notice. How do you advise from there? What's the advice to the mother and the newborn baby?
Regarding the feeds, they already come up already knowing what to do
Okay.
because they are educated, they are taught down in antenatal clinic
Yes.
that they are supposed to choose from between the breastfeeding 6 months and then wean the child
Yes.
or giving the formula.
I see.
So that they come already knowing what they are doing
I
about
see.
it. But the baby is given prophylaxis of vaccine whether we know the status or we don't know the
Right.
status, because we're not in a position then to test the child. But since we have this new PCR, DNA PCR thing,
Right.
then we haven't started practicing it
Right.
here in Maluti, but it's online already.
Right.
But then after knowing the status, we treat as they're supposed to be
Right.
treated.
Right.
The mother, we continue giving the regime she's already getting if she was on ARVs. But if she wasn't on ARVs, she only got the prophylaxis. We continue with the education on ARVs until she starts her ARV treatment.
No.
And yes, that's what we do.
How many choose formula? How many choose breast?
Jeez.
Well,
That
half and
I'm
half.
not sure. That
Okay.
I don't have the statistics of that.
No,
I
but
think
just
they
about. Is it
probably.
half and half, you think?
Yeah, I think so. I think so. Because of the, probably our community, they have, most of them, they have a problem with the formula because they don't know where to get the formula.
You
So
don't give the formula.
it is only when there's some donor
Yes.
who gives the formula.
Yeah.
Yes. But otherwise the hospital, we don't have.
So then when they make the choice,
When they make the choice,
Yes.
then
you have to explain to
we
them.
have to explain to them the formula would be costly. Probably they have to think otherwise. But
Yes.
most of them, because of the formula, they cannot get the formula, so they prefer to breastfeed for 6
Okay.
months and then
Right,
we
maybe we can go to that, is the antenatal clinic where that's discussed with the mother? Whether she goes on to formula, whether she goes on to breastfeeding,
yeah,
that's discussed.
in the internet.
So maybe we could go to the antenatal clinic, 'cause I'm really interested in that
Okay.
point.
Okay.
So now I leave you on that one, but
Mhm.
now the baby's born and you know the mother is positive
Yes.
and you know her CD4 count.
Mhm.
So she's either on ARV or she's not, right,
Mhm.
at this
Yes,
point.
At this point.
And
yes.
then let's go back to the ordinary person who's picked up perhaps a non-pregnant woman or a man,
Mhm.
so they're positive,
Mhm.
and then they come into this clinic,
Mhm.
and then and you know their CD4 count.
Yes.
So then what's the routine? Yeah.
Okay. They know their CD4 count. If the CD4 count is above 200,
Yeah.
they are given the ImmuBoost medications or the supplements, if I may call them. They are given that, and they come for their checkup every month or after every 2 months, depending on the condition of the patient. And they're also treated for every opportunistic disease that
Okay.
come along the way. If the CD4 count is below 200 or 200 and below,
Yeah.
then they go for pre-heart counseling. It depends on the understanding of the patient. If they understand much quick, then they go for 2 sessions, mostly at the most. But if the understanding is very low, or they go for 3 sessions, up to 4 sessions after we've known their CD4 count, and then when they are ready, after questioning and interviewing them, then we find that they are ready, they start the ARVs.
Right, so you just until you feel they understand.
Feel that, yes,
Yeah.
then they
Right,
we want to make sure that they are going to comply with the whatever.
right.
It's
Do you do
expected.
that yourself? Do you do that?
No, we have counselors. I just chip in when I see the need.
Yeah.
Say that the patient comes in, we take the vital signs and the history at the history room.
Yeah.
And then I find out as we are talking, I find out that there is some need of
Yeah.
re-emphasizing whatever the facts. I do that as I take the history. But then if it needs to be referred back to the counselor, that's what we do.
Right, right. You train, who trains the counsellors? Where they're trained?
It's us.
So you can also talk to counsellors, just we like to get everybody's angle, if we can do that. So I won't push you on that one.
Okay.
Let me push you on a different one. Once somebody's on ARV, how well does it work to monitor them? They have to come for a meal.
They come here for their refill, to refill the medications, and like I said, they come also to treat the opportunistic diseases. So the only way that is in place, they come here and every month or every after 2 months.
Yeah.
for checkup.
Yes.
Then we know what is going on with them. But in the village, we have the village health workers who are trained on home-based care, not only on home-based care, dealing with the minor ailments,
yes.
but also to manage the patient who's on ARV at home.
I see.
So the continuity of the care is also in the village with those people that are trained. Although it's not, they're still struggling with the people who are living with HIV, because they don't usually disclose their status. But then there are those that are free to communicate with the home carers, their status. But besides that, we have the relatives who bring them in here for pre-heart counseling. We don't encourage anyone to come by themselves for pre-heart counseling because they may not even comply. But if there is somebody from the home who comes with them, then that person is helping us with them to comply and treatment.
Do you keep records, for instance? Do you know how often they've got to come back here?
Yes.
The village worker doesn't do the treatment, just encourages them.
Yes.
So they've got to come back here.
Yes.
So you keep records here.
Yes, we keep records here.
So maybe we could look at the records when we finish worrying you, just to see how much they come back and who comes back.
Let me see if the file will do. We keep the files for everyone who comes in here, each being they are already taking the ARVs or they are getting immune boosters. We keep the record in the files. These are the files over here. And so we write down on the file, it's like this.
And then if they don't come and you don't see them?
If they don't come, like what we've done is, these ones we know they are here, they've come for their refill, but these ones, this line here, it's those that they didn't come on this month.
So in October, those came, those were due to come in October.
Yes.
But they haven't come.
They didn't come.
Right. And do you keep statistics? Do you keep count?
We do.
Annual report. And is it, perhaps I could just see just what percentage do come?
Okay.
It's easy, not if it's a trouble.
Okay. In which month?
All right, let's take last July. Last July. How many have come as expected? It means they come in October. Every 2 months they have to come, right?
That one would be, I don't know whether it would be easy. It's not very easy. Let me just give you the sample of our reporting as to how we
Friendly. Okay. Is this free service? Is it a free service?
Yes. I would say free because everything is free. They only pay 10 rands, the consultation fee, if I may call it. But for those who are outside our HSA, they still pay for the medications, excepting the ARVs. Because like I said, they come for any other opportunistic disease. They pay for those, but ARVs and the supplements, some of the supplements they get free.
TB?
Yes. TB is free.
You call that opportunistic disease, or you call it?
Yes, it's an opportunistic
So they pay for TB?
No, they don't pay for TB. Okay. But others, like they have the rash, they have oral thrush. Those things they pay. If they are outside of the HSA, but if they are in the HSA, they don't pay. They pay 10 rand for consultation. What we have here is this is the number of people that are enrolled in the care.
Okay, 1,374, right?
That was in August.
August, yes.
So the number of people who are already started on ARVs is this.
818.
Yes.
Okay.
So we go this side to check whether the 818 did come.
Yes.
We check here.
Right.
So it means 828.
Right.
828. It means there are some who were transferred in, since the number is up with 10.
Yes.
There may be some who were transferred in into the care already on ARVs, thus adding up to the number.
Right. So
that was the month of only the month of August. Okay. But this number is an accumulative from the year 2003 up to now.
I see, so it's
up
a
to
cumulative
August. Yes.
figure, right.
That's all, everybody that has been treated. 1,000.
Yes, 1,374 that is in the care. But those who are on ARVs, it's 828 from 2003 to August.
And what is the population of the villages which you help? In other words, this hospital has access to how many people generally? So that we can understand if it's 1,000, but is the community a community of 2,000 people or 10,000? Or what's the...
I don't know how to get the statistics, but before you go, I'll have it.
Okay.
I'll try to find out some people who can help me with it. But it's not more than, it's not less than, I suspect it's not less than 6,000. I suspect.
And
But you also have people who come all the way from
All the way
city.
from Guting. Dadema is near from
Yeah.
Guting.
Yes.
Listening further, why is that? Why are people coming from Kuting to your
I've tried
particular
to
service?
investigate from them, but all they say is we don't want. Some say they don't want to be treated at their places because they are known, or
Right.
because they know of somebody who's been ill-treated just because of the status.
yeah.
Some say we just like to be treated in Maluti, period.
Mm.
So we don't have a way of like chasing them out. We just tend to
Out
accept
them.
them.
Yes.
And until the person says, okay, you've done your best, now I feel comfortable to go back to my home.
Okay.
Like everywhere else, you have more women than men
Mm-hmm.
that come.
Mm,
Nearly twice as many women as men.
that's
Why,
true.
why do you think?
Hmm.
Everybody finds it.
It's I really don't have a definite answer, but I would think men generally they don't like go to see the doctor. They like, and unless he's very sick to be dragged by somebody to the doctor. Otherwise they shy away from
Right.
health services.
Right.
I
I
would think
think
so.
when the men do come, are they sicker?
Yes,
Mm.
it's always the case. They come when they're very sick.
Really, really sick.
But women, they would also come for testing, even if they are not very
Even
sick.
not sick, yes, and of course if they're pregnant. Do you have a clinic for other sexual diseases, like gonorrhea?
At the present moment, no, we don't have. They are treated in OPD, and those that are already here in the
Yeah.
chronic care, they are treated here.
Right,
So we don't have.
right. But if you test in OPD, the man who has a discharge, he goes to OPD.
Yes, if they're not positive.
If they're not,
If they're not positive, if they're not HIV
when they
positive.
go to OPD, will they be tested, offered testing there?
Yes, that's why I said some are referred from the OPD to come and test here.
Right.
Once the doctor says that it has been this case repeatedly, then
Right.
they refer them to wellness center for testing.
Right. I don't want to push anymore, just ask one question. At the end of the year, or after a few months, I think it's useful to make a summary. I have 800 patients who should be coming this month. How many came? So one can see how many people drop out of treatment. I don't think it's easy to get that figure from here and from here, but you could do it.
Yeah,
And it's a very useful figure, then you know how successful you've been, because otherwise they disappear. Unless, or even if you send the village worker, if it can disappear, if the information doesn't come back to you. You could have deaths. Would you know about deaths?
Yes, that's the village health workers report.
Okay.
And those that die in the hospital, while admitted in the hospital, we know.
Yes.
Yeah, but we have the record of death.
Right. Right, that would be good statistics.
Yes, definitely.
It's a way of sort of evaluating outreach, because you can be doing a very good job here, but if the patients don't come back, same with TB, then much of your treatment's wasted, right?
Yeah,
Not
that's true.
wasted, but hard to see what it is.
I also have those that it would be, we already know that in the 800 there are some that we already transferred to the health centers. Like I said, we have 4 health centers. They are already dealing with the chronic care of HIV positive people. So
Yeah.
some have already transferred to different
The reason
clinics. health
they
centers.
asked that because it's nearer their home, or why they
It's nearer their home.
Okay.
Yes.
Okay, so that's
So they
understandable.
try that.
I think also, sorry, the hospital has some community projects related to HIV, so perhaps you could say something about your income generating activities, working together on guidance with the community.
I wish Ndate Matlara was here, who's working
Right.
full time there. But all I can say is, yes, we do have the income generating projects going on in the villages, different villages. It's not all the villages that we serve, but those that few that are being helped. So they are, what they are doing at the present moment, they are encouraging everyone, living positive and not positive people, to have something that they do for themselves, not waiting for some government, whatever, donor to come and give them, especially when it comes to gardening. So we have the donors who are giving out some seeds so that they can give to those people who are living with home-based carers and other people who are supposed to be given or who have the need of such.
Right.
So they have their gardening programs.
I wonder how much time it would be nice to talk to a counsellor. To be a counsellor that you have here, so then we just get their perspective, and even if they don't speak English, my colleagues can talk to them.
Just before, I have a question. Do you is there such a thing as a hospice here? So there's really no place for someone with no family to be taken care of in their last days? In this whole country or just in the community? There's no hospice in the whole country. And no hospice generally, I'm not even necessarily talking about HIV, but just even a general hospice, it doesn't exist.
Doesn't exist in the country.
So really people are fully dependent on families.
Yes.
And that's a huge burden, I
It
guess.
is a burden.
For most families, especially with diseases which are beyond their ability to really
That's right.
take care of.
And what about the children? I see outside you say orphans, you have a service for orphans.
Yes, we do have orphan care. Orphan care in a sense of, in the income generating projects, orphans are included in this sense. The village health workers and there are gardening instructors who are already trained on doing the gardening. So the village health workers with those officers, they help the orphans with their gardens at home so that they can produce and have food in their homes. Because we find that there is a field, but then there is no one to help them to plant something in the field. So that's what they do. Besides that, we have some donors who are helping them with the school fees.
Right.
Yes. So some orphans are going to school, those that are still at the school going age.
Right. You have responsibility. Say, for instance, one of your patients here, to your knowledge, mother dies. Then do you manage to find out, well, so who will help with the children, or do you think that's the family or the relatives responsible?
At this point in time, it's the relatives who deal with it. And we haven't gotten that far yet.
It's okay. Okay.
Yes. Is there any record of the deaths that occur in the general ward but found to have been caused by HIV/AIDS? There's people who didn't come for treatment here but came for other diseases, but and then.
Yeah, we have somebody who keeps that statistics.
Okay. And it's quite significant, the number of those deaths.
I think so. I should think so.
Okay.
And I should think so.
I'm not sure how much time, but I'd still like
Oh, we're
to
fine.
I'd like to speak to the counsellor.
Okay.
Camera or the video will be there, so I didn't want to appear in but I've appeared.
Can you tell me, just tell me your name and look at me, tell me your name, what you do here?
Oh, I'm Ebile Mantuming Matiti. I'm a registered nurse, and I'm the third in charge in the ART clinic.
And you mentioned that I heard the word theater when you were talking earlier.
Yeah,
You're
I was
so-
working in the operating theatre for some time.
Oh, operating as in
Yes.
the medical theater.
Medical.
I thought you were going to sing and dance. for
No,
us.
no, no. Singing I can do, but dancing, oh, it's disaster.
People come here, or the relatives come, is there a session with them on prevention of transmission?
Yes,
Yeah,
yes,
do you
yes.
do that? The counsellor does
The
that?
counsellors do.
In the clinic?
Mm. In the clinic, we give the general health education.
Okay.
Yes, but as the relatives take the patient to the counsellors, that's when it's given.
Okay. But in the clinic you do a
The
general,
general
yes,
counselling.
describing how it's transmitted
Yes.
while the patients are waiting here.
Yes.
You have videos,
No,
personal.
personal.
Would
We
you
do
be-
have videos, but we don't have those that are straight to the point. It's
Okay.
like dramatized, and
Right.
sometimes they just sit there and laugh, enjoy the drama, but they didn't get it. But if we do
Right.
it personally, we find
Right.
it's worth it.
Would videos help? I've seen them used in other clinics.
Mm.
A video, condoms and discussion.
Mm.
You don't, would
We-
they help you?
Yeah, they would. They would if we can get some more. We do have, but they are like they've gotten used to them that so much that it loses its meaning.
Yeah.
So they just enjoy the whatever
Yeah,
the
right.
drama.
You give out condoms, is it?
Yeah, yeah. We
And
do have
female
condoms.
condoms?
Yes,
Show me
both
the box.
male and female.
Show me the box. They photograph me
Oh.
looking at a box.
Okay, bring it.
The condom cream.
Let
What my message is, but the scope is still wide to,
Yes,
Right.
to improve on
and
that.
to be more
Right.
targeting.
Exactly.
Right, in South Africa too, many ones have been worked out. Some are games even. I've seen one that's like, the game of Monopoly.
Yes.
A board, which you give to young people and you play the game and the message comes in and kids love the game. How much goes into their head, into the behaviour, nobody knows, but at least it interests them.